Hello everyone, welcome to NEET PG Live Daily. Myself Dr. Apoorva Mittal, and today we'll be continuing with our previous year questions session. Last time I was not able to complete this session because there was some problem with the net. So what I'll be doing today, I'll be just going through the initial questions which I discussed in detail quickly, and then I'll be discussing the part which I couldn't cover the previous day. So welcome to Unacademy friends. Unacademy is India's leading platform for online courses, and by getting the Unacademy Plus subscription, we'll be able to avail all the live classes which are available for the 19 subjects, and also interact with the educator for all the 19 subjects. Also, we'll be having daily test series and analysis through which we can evaluate the progress, and also live doubt clearing sessions through which you can clear the doubts pertaining to the subject. Is it clear, friends? So that this is the advantages of Unacademy Plus subscription, and by getting the Unacademy subscription, we can get it for either for 12 months or 24 months. Okay, and if you apply my code, and that is Apoorva Live, APOORVA Live, you can get 10% discount on the sale. So these are the advantages of Unacademy Plus subscription. Now coming to today's topic, that is previous year questions. Okay, so could you please tell me the drug of choice? Question number 1, the drug of choice for reversal of neuromuscular blockade by vecuronium. Okay, what is the drug of choice for neuromuscular blockade by vecuronium? Is it A, edrophonium, B, neostigmine, C, sugamadex, or D, pyridostigmine? What should be the answer for this? Drug of choice for reversal of neuromuscular blockade by vecuronium: A, edrophonium, B, neostigmine, C, sugamadex, or D, pyridostigmine. What should be the answer, friends? Please tell me the answer. For vecuronium, what should be the reversal agent of choice? Okay, can anyone tell me what group does the vecuronium come into? What it is? What group does vecuronium come into? See, the skeletal muscle relaxants, first of all, the skeletal muscle relaxants, they are in turn divided into the depolarizing muscle relaxants and non-depolarizing muscle relaxants. In non-depolarizing muscle relaxants, we have in turn two groups, which are benzyl isoquinones and steroids. Okay, now these benzyl isoquinones, the example are atracurium, cis atracurium, okay, atracurium, cis, and mevacurium. In the steroidal group, we have vecuronium, rocuronium, okay, and pancuronium. These are the examples of the steroidal group of drugs. Now, what we have to remember is these benzyl isoquinones, they release histamine. Okay, they release histamine, but they does not have any vagolytic action. They don't have any vagolytic action. One more thing we have to remember. But the steroid group of drugs, the pancuronium, okay, pancuronium, it has vagolytic action, and therefore there is increase in the heart rate whenever pancuronium is given. Now there is the neuromuscular blockade reversal agents. Okay, Dr. Rahul, welcome to the class. Yes, it is sugamadex, because sugamadex, okay, sugamadex, it is a cyclodextrin. The answer for this is C. Why? Because sugamadex, which is there, it is a gamma cyclodextrin, and it is specific. It is specific for the steroidal group of agents. Remember, it is specific for steroidal non-depolarizing muscle relaxants, and therefore it is specific for rocuronium or vecuronium. Okay, so it is highly specific for rocuronium or vecuronium. So therefore our answer is Sugammadex. What does it do is, this is the muscle relaxant. Okay, this muscle relaxant is encapsulated by the Sugammadex. It is encapsulated by the Sugammadex, and therefore it degrades this muscle relaxant, So this is how Sugammadex works. So just remember, Sugammadex, it is a reversal agent which is specific for the steroidal group of non-depolarizing muscle relaxant. Is it clear? Any doubts? Dr. Ragul, any doubts for this? Okay, remember it is a cardiovascular and there is no need of anticholinergic administration because as seen with neostigmine, we need atropine or glycopyrrolate also. With Sugammadex, there is no need of anticholinergic administration. Okay, so answer for this is Sugammadex. Is it clear? Is it clear? Okay. Coming to question number 2. Which of the following is a well-known adverse effect of etomidate? Okay. Which of the following is a well-known adverse... Dr. Ragul, what didn't you understand? What was not clear? Please let me know. Dr. Ragul, what was not clear in the first question? Let me know. I'll just explain it to you. The Sugammadex, it is a muscle relaxant which is a gamma cyclodextrin, and it encapsulates the steroidal muscle relaxant and therefore degrades it. So it is specific for the steroidal muscle relaxant which are rocuronium and vecuronium. That's why the answer is Sugammadex. Okay. So coming to question 2. Which of the following is a well-known adverse effect of etomidate? Is it A, myoclonus and hiccups, B, increased intracranial tension, C, increased cortisol suppression, or D, all of the above? What should be the answer for this? A well-known adverse effect of etomidate. Myoclonus and hiccups, B, increased intracranial tension, C, increased cortisol suppression, or D, all of the above? Please answer to this. Okay, please answer to question number 2, Dr. Ragul. And others, please answer to question number 2. A well-known adverse effect of... Yes, it is C, that is increased cortical suppression. Because see, etomidate, it also causes myoclonus and hiccups. It can cause but it does not cause increased intracranial tension. And a specific adverse effect of etomidate is increased cortisol suppression, because what happens is it inhibits an enzyme which is 11-beta hydroxylase. Okay, it inhibits this enzyme 11-beta hydroxylase, and therefore the formation of cortisol is suppressed. So it causes adrenocortical suppression, but it is a specific adverse effect of etomidate. If the question would have been most common adverse effect of etomidate, then what would have been the answer? What would have been the answer for most common adverse effect of etomidate, Dr. Ragul? This is the most specific adverse effect of etomidate. Most common adverse effect of etomidate, what would have been the answer? Can you please tell me? I'm waiting for the answer. What is the most common adverse effect of etomidate? The specific adverse effect of etomidate, yes, it is increased cortisol. No, it is not A. The most common is, remember, nausea and vomiting. Okay? If the question is asked, yes, Dr. Ragul, it is vomiting. The most common adverse effect is nausea and vomiting. Specific is increased cortical suppression. It can cause myoclonus and hiccups. So in this, the best out of these answer is C, that is there is increased cortisol suppression. So some important points about etomidate. Okay, etomidate, it is an IV induction agent. It is an IV induction agent, right? And it is a imidazole derivative. It is a imidazole derivative which is milky white liquid, okay? And it has rapid onset and brief duration of action because it is highly lipid soluble. So this is imidazole derivative with high lipid solubility. Now it is mostly seen in the cardiac OTs. Okay, etomidate mostly used in the cardiac OTs. Why? Because it is the most hemodynamically and cardiostable IV induction agent. It causes very less cardiovascular and respiratory depression, and therefore it is an agent of choice in cardiovascular surgeries, and also coronary perfusion pressure is maintained when it is given with fentanyl. Now, adverse effects, one of the important thing is adverse effects. It causes intense pain. Okay, it causes intense pain on injection. It causes intense pain on injection, and that is because of the presence of propylene glycol. Remember this. Okay? Dr. Ragul, please remember this. Others, please remember this. The injection of etomidate is highly painful, and that is because of the presence of propylene glycol. And as I told you, the most specific adverse effect is adrenocortical suppression because of the inhibition of enzyme 11 beta hydroxylase. Is it clear? Is it clear? And most common is nausea and vomiting. It can produce hiccups and myoclonus also. Now, coming to the question number 3. Last time there was some doubt with this. I'm asking question number 3. What should be the answer? The current recommendation for minimum preoperative starving period for solid food. Okay. According to the ASA guideline, what is the minimum preoperative starving period for solid food? Is it A, 4 hours, B, 6 hours, C, 10 hours, or D, 8 hours? What should be the answer for this? Minimum preoperative starving period for solid food. Dr. Ragul, what should be the answer for this? D. Is it D or what it is the answer? The starving period for solid food. A, 4 hours, B, 6 hours, C, 10 hours, or D, 8 hours? What should be the answer for this? Okay. Yes, it is 8 hours. Can you tell me? Yes, Dr. Ragul, it is 8 hours. Can you tell me, according to the ASA, you have to remember the rule of 2, 4, 6, 8 hours. Okay, you have to remember the rule of 2, 4, 6, 8 hours. 2 hours is for what? The minimum preoperative starving for 2 hours is for the clear liquids like water or pulp-free juices like apple juice. Okay, 4 hours. 4 hours is for what? 4 hours minimum preoperative starving period is for what? It is for breast milk. Okay, remember, it is for breast milk. No, it is not for liquid food. It is only for breast milk. Remember, this is a very important point. 6 hours. 6 hours is for non-human milk like cow milk or buffalo milk or infant formula milk. Okay? Or light meal. What do I mean by light meal is having milk along with 1 or 2 toast. Okay, that is light meal. But 8 hours it for the solid food, matlab heavy meal or the heavy meal which is containing of fat or oil, that is for 8 hours. So the best answer out of this is 8 hours. Is it clear? Any doubts in this? Any doubts in this? So according to the ASA guidelines, the minimum preoperative starving period for solid food, it is 8 hours. It is 8 hours. 6 hours is for a very light meal, that is with the milk, 2 or 3 toast. That's it. So this is the minimum preoperative starving period. Please remember this. This can be asked as a clinical based question also. Okay. Now coming to question number 4. A patient was undergoing surgical procedure under GA. Suddenly he developed tachycardia, sweating, hypertension and tachypnea. What is the immediate step to manage the situation? Okay, a patient was undergoing surgical procedure under GA, suddenly tachycardia, sweating, hypertension and tachypnea. What is the immediate step to manage the situation? A. IV beta blocker. B. Abandon the surgery. C. Deepen the plane of anesthesia. Or D. Nothing is required. What should be the answer for this? Undergoing surgical procedure, what is the next best step? Yes, Dr. Ragul, very good. It is C, that is deepen the plane of anesthesia. A. Dr. Kunal, yes, it is deepen the plane of anesthesia as we discussed the previous day. And Dr. Ragul, no, it is not D, it is deepen the plane of anesthesia because these are the signs of a light plane of anesthesia. Okay, so the given patient is showing the signs of light plane of anesthesia and intraoperative awareness. Dr. Kunal, I am just repeating quickly the previous questions because that time I could not complete the class because of some net issues, and then we will go on to the new questions. Okay, so the given patient is showing signs of light anesthesia and intraoperative awareness. Signs of light anesthesia are tachycardia, hypertension, lacrimation, perspiration. That means light plane of anesthesia means what? The patient is aware. Okay, the patient is aware about the procedure. There is some consciousness level, that is light plane of anesthesia. So whenever the patient is aware, what will happen? The patient will be tachycardic, he will experience some pain, okay, hypertensive, because of that lacrimation, the sympathetic activity will be more. There will be eye movements, there will be, okay, preserved reflexes, and because of the preserved reflexes, there are more chances of laryngospasm or bronchospasm. Okay, and movement on the painful stimuli will also be seen, tachypnea, and also beta waves on EEG. Okay, and also beta waves on EEG. So these are the signs of light anesthesia. So Dr. Ragul, you have to deepen the plane of anesthesia because patient is under GA, but suddenly he has tachycardia, sweating, hypertension and tachypnea. So the answer should be deepen the plane of anesthesia. That should be the immediate step. Okay. Now, coming to question number 5, features of light anesthesia are all except. Features of light anesthesia are all except A. Desirable in certain high-risk patient. B. Patient may feel pain during procedure. C. Post-traumatic stress disorder is a complication. Or D. No explicit memory for the event. What should be the feature? What are the features of light anesthesia except? Please answer this question carefully and quickly. Dr. Ragul, Dr. Kunal already knows this answer. What should be the answer for this? Features of light anesthesia are all except. Guys, I'm waiting for the answer. Features of light anesthesia are all except A. Desirable in certain high risk. B. Patient may feel pain during the procedure. C. Post-traumatic stress disorder is a complication. Or D. No explicit memory. Okay, yes, the answer is D. Actually, people have confusion between A and D. C. Obviously, light anesthesia, I told you, patient may feel, and because the patient will remember about the event, there might be post-traumatic stress disorder. So these two options are for sure ruled out. Now, why the answer is not A and why the answer is D? Because in certain high-risk groups, for example, in the cardiac patients or also in the obstetric patients, in the obstetrics patients especially, we need not deepen the plane of anesthesia, okay? So we can keep the light anesthesia, and in the cardiac patients, the patients might not tolerate that much dose or that much amount of anesthesia. So therefore, we can keep the light anesthesia. So therefore, it is desirable in certain high-risk groups. But if there is light anesthesia, obviously there will be explicit memory for the event. So therefore, out of the 4, the best answer is D. That is no explicit memory for the event, because if there is light vein of anesthesia, the patient will be aware and he might have memory for the event. Is it clear? So these are the features of light anesthesia. Okay, now I want to discuss with you the stages of anesthesia. Okay, so Goodell, he described 4 stages of anesthesia, but remember, these 4 stages of anesthesia are true only with ether. It is not true with any other anesthetic agent. Okay, so Goodell, he described 4 stages of anesthesia, and these 4 stages are true only and only with ether. Please remember this. Now, could you please tell me the other contribution of Goodell into anesthesia? Any other device, okay, which is named after Goodell? Any other device which is named after Goodell in anesthesia? It's a very important topic. He described 4 stages of anesthesia. Also, one more device is there in the anesthesia, which is named after Goodell. Dr. Kunal, Dr. Ragul, could you please tell me what should be the answer for this? Yes, Dr. Kunal, it is oropharyngeal airway. It is oropharyngeal airway, okay, which prevents the, sorry for the spelling, it is oropharyngeal airway. It prevents the tongue fall against the posterior pharyngeal wall, and therefore it maintains the patency. Therefore, the answer is oropharyngeal airway. Now, Goodell, he described 4 stages of anesthesia. First stage is the stage of analgesia. Okay, it is a stage of analgesia, and we have given the anesthetic agent till the loss of consciousness. Okay, so beginning of the inhalational agent till the loss of consciousness, that is the first stage. Second stage is the state of excitement or delirium, that is from the loss of consciousness till the beginning of the regular respiration. And remember, it is in this stage that we have roving of the eyeball, the pupils get started dilating, and also the first reflex to be lost, it is the eyelash reflex, which occurs in the second stage. Okay, remember this, the eyelash reflex is also lost. About the stage 3, that is the stage of surgical anesthesia. Remember stage 3. Okay, it is the stage of surgical anesthesia which we need to perform the surgery, and that is from regular respiration till cessation of the spontaneous respiration. And this in turn is divided into, and surgical, for surgical anesthesia it is, okay, plane 3 of stage 3. Remember this, we need plane 3 of stage 3, and stage 4, that is medullary paralysis, in which the patient's respiratory response will be lost. Okay, medullary paralysis is there. So appropriate for the surgery. Remember, this is one of the question. It is stage 3 plane 3, and the other question that is asked, the first reflex to be gone is eyelash reflex, and that is in stage 2. That is the stage of excitement or delirium. Is it clear? Is it clear, guys? Any doubt? Dr. Ragul, Dr. Kunal, any doubt in this? Any doubt in this? Can I move? Can I go to the other question? Stage 3 plane 3 is appropriate for the surgery, and the first reflex to be gone is the eyelash reflex. Okay. Coming to question 6, which group of fibers is least susceptible to local anesthetics? Okay, which group of fibers is least susceptible to local anesthetics? A alpha, A beta, B or C? A alpha, A beta, B or C? What should be the answer for this? Which group of fibers is least susceptible to local anesthetic? Dr. Ragul, what should be the answer for this? Okay. Depending upon the diameter and myelination, okay, the nerve fibers are divided into A, B and C. What should be the answer for this, friends? Least susceptible to local anesthetic. Dr. Ragul, what should be the answer for this? Okay, so depending upon the diameter and depending upon myelination. Okay, A fibers are what type of fibers? A fibers are large fibers. Okay, they are large fibers, and yes, they are myelinated. They are myelinated. Okay, because of the myelination. Okay, okay, and B fibers, they are medium fibers. They are medium and they are partially myelinated. Partially myelinated. And the C fibers, they are small fibers and they are not myelinated. Okay, and they are not myelinated. Now, the A fibers, they are large and they are myelinated. Because they are large, okay, because they are large, they are less susceptible to the local anesthetics. Local anesthetics, how do they act? They have to, the local anesthetics, okay, they have to penetrate the membrane. They have to penetrate the membrane. Okay, in what form? Dr. Kunal, local anesthetics, okay, they penetrate the cell membrane in what form? Is it cationic or anionic form? Okay, local anesthetics which are weak bases, can you please tell me? They penetrate the membrane in which form? Penetrate the membrane. How do local anesthetic act? How do they act? In which form? In which form? Is it ionic or non-anionic form? Please tell me the answer for this, Dr. Kunal. Local anesthetics, they are weak bases, right? They penetrate the membrane in which form? Is it ionic or non-ionic form? Dr. Kunal, I am waiting for the answer. Yes, it is the non-ionized, okay, unionized or the non-ionic form. Why is it so? Because these are the weak bases. Okay, these are the weak bases. The pH of here is around 7.4. Okay, it is 7, and it is only in the non-ionized form it can penetrate the membrane. Where do they act? Where do they act? On which channel do they act? What do they do? How do they cause Okay, how do they cause the impulse not to be transmitted? On which channel do the local anesthetics act? Is it potassium? Is it calcium, magnesium, or sodium? Dr. Kunal, Dr. Siva, what should be the answer? I'm just revising the local anesthetics with you. On which channel do they act? The local anesthetics. Please reply. Please reply to this question. The local anesthetics on which channel? Okay, they act on the voltage gated. Yes, Dr. Kunal, it is voltage gated sodium channels. Okay, in which form do they act? Is it in the cationic form or is it in the non-ionic form? Okay, so here are, I'll just change the color. Here are, Dr. Siva, is it clear? Any doubts in this? Okay, these are the voltage gated sodium channels through which the influx of the sodium takes place normally. Now, what do these do? What do these do? Okay, they in the cationic form, remember, in cationic form, they block these sodium channels and therefore influx of sodium, okay, of sodium does not take place and therefore the impulse is not conducted. Dr. Siva and Dr. Kunal, is it clear? Is it clear? Is it clear? This is very important. These 4 points about the local anesthetics is very important. Okay, Dr. Kunal, that day we didn't discuss about all these things. So today I've discussed the local anesthetics. These are the weak bases, penetrate the membrane in the non-ionic form. They act mostly on the voltage-gated sodium channel and that too in the open state. Okay, and that too in the open state. Dr. Ragul, is it clear? Is it clear? Okay. So this is how the local anesthetics work. This is how the local anesthetics work. And see, they have to penetrate the membrane, right? So they penetrate the small membranes more than the large membranes, but the myelinated fibers are more susceptible than the partial myelinated fibers. So the sequence is BCA. Okay, the B type of nerve fibers, they are more susceptible than C than A. In A, it is in turn divided into A alpha, A beta, A gamma, and A delta. So in this, it is A delta more than A beta more than A alpha. A alpha is the one which carries the motor and proprioception, and therefore these are least susceptible to local anesthetic. Okay, so just remember this classification. Type A is A alpha, A beta, A gamma, A delta. Okay, A alpha, they are myelinated and large bar and they carry the motor and proprioception. A beta is touch and pressure, gamma is muscle spindle, and delta is pain and temperature. The B fibers, these are preganglionic autonomic. Can you tell me what type of impulse is lost first? Is it motor, sensory, or autonomic? What is the sequence of events which are lost first? The first thing to be lost, is it motor, sensory, or autonomic? What is the sequence in which these impulses are lost? Dr. Kunal, Dr. Siva, can you tell me? Okay, in which sequence? I told you the fibers, that is BCA. But first, what is lost? Remember Assam. Okay, remember Assam, it is autonomic. Okay, then sensory, then motor. It is lost like this. Okay, it is lost like this. First the autonomic is gone, then sensory, then motor, and therefore the name is differential. Yes, Dr. Kunal, it is it is autonomic, then sensory, then motor, and therefore the name is, okay, the order of block, therefore it causes differential type of block. Differential type of block. Is it clear? Is it clear? Dr. Ragul, is it clear? Okay. Now coming to the next question. Highest concentration of oxygen is delivered through. Coming to the next question, highest concentration of oxygen is delivered through A. Nasal cannula, B. Venturi mask, C. Bag and mask, or D. Face mask and reservoir. Highest concentration of oxygen is delivered through A. Nasal cannula, B. Venturi mask, C. Bag and mask, or D. Face mask and reservoir. Please answer to this. Dr. Siva also please answer. Dr. Kunal, what should be the answer for this? I'm asking you about the oxygen therapy devices, and I'm asking highest concentration of oxygen is delivered through nasal cannula, venturi mask, bag and mask, or face mask and ventilation. D. Yes, it delivers 80% FiO2. Yes, it is face mask and reservoir. It is face mask and reservoir. Okay, so answer is D. That is face mask and reservoir. Okay. See, the oxygen therapy devices, whenever we are in need of oxygen, okay, oxygen delivery devices, it is in turn divided into two types. Okay, just remember the oxygen delivery devices in which the oxygen is delivered, it is in turn divided into two forms. That is low flow variable. Okay, variable performance, high flow fixed performance. Okay, fixed performance. What does low flow, okay, what does variable, okay, what does variable means? It is variable, that is the flow of the oxygen is fixed. Okay, the flow of the oxygen is fixed, but the performance of these devices are affected by, okay, the performance of these devices are affected by patient's tidal volume and respiratory rate. For example, हमने patient को nasal cannula लगाया. Example of variable, okay, nasal cannula. Okay, if it is at 2 liters per minute, this much oxygen it is giving, but the FiO2, the final concentration, it depends upon the patient's tidal volume and respiratory rate. That means in this the FiO2, okay, accuracy ki itna FiO2 it is giving, it cannot be predicted. That is the variable performance. It is affected by the patient's tidal volume and respiratory rate. Whereas in the fixed performance, like in cases of the venturi mask, okay, fixed performance in cases of the venturi mask, okay, it is fixed. Okay, it is fixed. It does not depend, it is not affected by, there is no entrapment of the air from the atmosphere. So it is not affected by patient's tidal volume and respiratory rate, and FiO2 in them can be predicted. FiO2 in them can be predicted. So these are the two types of the oxygen delivery devices. Is it clear till now? Is it clear till now? So the oxygen delivery devices, these are low flow variable performance equipment, and oxygen is supplied at a fixed flow like 2 liters per minute, 4 liters per minute, but that is only a portion of inspired gas, and this does not meet, okay, it does not meet all the inspiratory flow demands of the patient. Okay, the performance of these devices, they are affected by changes in tidal volume and respiratory rate. The performance in this are variable, and therefore FiO2 accuracy cannot be predicted, and they are cheap and better tolerated. Is it clear? For example, nasal cannula. ठीक है, nasal cannula, they deliver around FiO2 of 0.24 to 0.4 at a flow rate of 1 to 6 liters per minute. See, nasal cannula, we cannot give it at a very high rate. We cannot give the flow rate very high. Why? Because if the flow rate is very high, what is the disadvantage of nasal cannula? The disadvantage is if the flow rate is very high, what will happen? The air is not moist. Okay, the air which we are giving is not moist, it is dry. If it is dry, it can cause nasal crusting. ठीक है, नेजल क्रस्टिंग या फिर वहां से ब्लीडिंग हो सकती है. तो नेजल कैन्युला से वी कैन नॉट गिव अ वेरी high flow rate. Advantages of nasal cannula is it is better tolerated. The patient can communicate, right? And there is no need to remove the nasal cannula while having the food. So these are the advantages of the nasal cannula. What about the simple face mask? See, this is the simple face mask, the plastic mask. ओके, इसका FiO2 इज बिटवीन 0.4 to 0.6 और इसका जो फ्लो रेट है इट शुड बी बिटवीन 5 to 8 liters per minute. Okay, so the simple face mask flow rate should be between 5 to 8 liters per minute. ठीक है, this is the simple face mask or the Hudson's mask. Okay, now coming to this, अपना question, face mask and reservoir. Remember, मास्क के साथ अगर ये बैग है, द रिजर्वायर बैग, ओके, if with the mask this reservoir bag is present and if this vent, okay, through which the expiratory gases can come out into the atmosphere, if this is present, then this is the non-breathing mask. Okay, it is the non-breathing mask and it gives the maximum amount of oxygen concentration. FiO2 is 0.8, okay, at 10 liters of oxygen. Okay, remember, if the vent is present, if this vent is not present, then it is a partial rebreathing mask. If this vent is not present, then remember it is a partial rebreathing mask. Why? Because the exhaled gases, they cannot go out. Either the vent hai, it is going out. The exhaled gases, it cannot go. It will go back into the reservoir bag and the patient can rebreathe it. So it is a partial, if the vent is not present, it is a partial rebreathing mask. Is it clear? Dr. Kunal, Dr. Siva, is it clear? So this is, okay, so this is the face mask with reservoir, that is non-rebreathing mask and it provides the maximum oxygen concentration. Now coming to the fixed performance, okay, fixed performance, I'm telling you, it provides complete source of inspired oxygen and it is not affected by change in the respiratory pattern. It delivers accurate FiO2 because it does not depend upon the tidal volume and the respiratory rate, and therefore it is a fixed performance. Example of this are Venturi mask. Okay, Venturi mask. See, these are the equipments which I used यहाँ पे between the mask and the from where the oxygen supply is there, we will put this, and depending upon the constriction, okay, depending upon the constriction, it will determine the FiO2 level. It will determine the FiO2 level. So these जहाँ पे भी ये कलर कोडेड है फेस मास्क और ऑक्सीजन सप्लाई के बीच में ये जो है, इफ दीज आर प्रेजेंट देन दिस इज द वेंचुरी मास्क. इज इट क्लियर? Is it clear? Any doubts, Dr. Kunal? Any doubts in this? So Venturi mask, remember, it is Venturi effect, which is based on Bernoulli principle. That is relationship between the velocity and pressure exerted by moving liquid is described by Bernoulli's principle. As the velocity, okay, यहाँ पे जितना constriction होगा, ठीक है, जितना ज्यादा हमने velocity increase करेंगे, उतना ज़्यादा pressure exerted by the fluid, it decreases. Okay, as the velocity of the fluid increases, the pressure exerted by the fluid decreases, and that is Venturi effect, which is depending upon the Bernoulli's principle, So remember this. Okay, other examples of the high flow, okay, or the fixed performance are the air entrapment and bag and mass ventilation. In bag and mass ventilation, remember AMBU. And remember the full form of AMBU. It is artificial manual breathing unit. It is what? It is artificial manual breathing unit. And adults it can provide a volume of 1200 ml, pediatric 500, and neonatal 250 ml. So this is the different oxygen therapy devices. Is it clear? In detail about the oxygen therapy devices, I'll be discussing tomorrow at 11:30. Okay, so tomorrow at 7:30 p.m. on YouTube, I'll be discussing in detail about the oxygen therapy devices. It is also a very important topic. Okay, and just now I have given you a brief introduction. Tomorrow I'll be discussing at 7:30 p.m. on YouTube about the oxygen therapy devices. Okay, now could you please tell me this answer? Question 8. What is the recommended duration of pre-oxygenation before intubation? Is it A, 1 minute of tidal volume breathing, B, 3 minutes of tidal volume breathing, C, 3 minutes of deep breathing, or D, 5 minutes of deep breathing? What should be the answer for this? Recommended duration of pre-oxygenation before intubation. 1 minute of TV, 3 minutes of TV, 3 minutes of deep breathing, or 5 minutes of deep breathing. What should be the answer for this? Please answer to this. Recommended duration of pre-oxygenation before intubation. 1 minute of tidal volume, 3 minutes of tidal volume, 3 minutes of deep breathing, or 5 minutes of deep breathing. Dr. Kunal? Other doctor, Dr. A, B, C, D, I don't know the name. Dr. Siva, what should be the answer for this? Why is pre-oxygenation given? What should be the answer for this? Dr. Kunal is telling me 3 minutes of deep breathing. Are you sure it is deep breathing? It is not tidal volume breathing? Are you sure that it is deep breathing and not tidal volume breathing? Okay. Pre-oxygenation. I'll just tell you. Pre-oxygenation. Okay, why is it done? To replace the FRC. Okay, to replace the FRC, that is the functional residual capacity. What is functional residual capacity? Okay, Dr. Kunal knows 3 minute 100% oxygen. Okay, fine. So let's discuss in detail about pre-oxygenation. In pre-oxygenation, we are replacing the FRC, which is the functional residual capacity. What it is the amount of air. Others, please answer. Amount of air remaining in lungs. Okay, remaining in lungs after normal expiration. Okay, so amount of air remaining in lungs after normal expiration, that is FRC. And by pre-oxygenating, what I am doing is I am denitrogenating the patient. So another name for pre-oxygenation is denitrogenation. Okay, denitrogenation. I'm replacing the nitrogen with the oxygen so that in apnea, ठीक है, during apnea, after giving the muscle relaxant till the intubation, during apnea the patient, ठीक है, patient oxygen reserve is maintained and there is no hypoxia. So that is the principle behind pre-oxygenation. That is the principle behind pre-oxygenation, and this pre-oxygenation, it can be done in 3. So answer for this is B. I'll just tell you. Okay. So okay. So the methods of pre-oxygenation. The methods of pre-oxygenation is first 3 minutes of normal breath. Okay, 3 minutes of normal breath with 100% oxygen. मतलब 3 minutes of tidal volume. Okay, it is 3 minutes of tidal volume with 100% of oxygen. The second method is either 8 deep breath. Okay, that is vital capacity for 60 seconds. Okay, the methods of pre-oxygenation, Dr. Kunal, 3 minutes of tidal volume, 100% oxygen, or 8 deep breath for 60 seconds. That is vital capacity. Or if we don't have time, we have to like quickly do the procedure, then it is 4 deep breath. That is vital capacity for 30 seconds. Is it clear? So these are the methods of pre-oxygenation, either 3 minutes with 100% oxygen, tidal volume, normal breath, or deep breath, that is vital capacity for 60 seconds, or 4 deep breath, vital capacity for 30 seconds. This will help us to pre-oxygenate the patient, and this will give us the time. Is it clear? So therefore the answer is 3 minutes of tidal volume breathing. Okay, 3 minutes of tidal volume breathing. Now question number 9. A patient, others, is it clear? Okay. A patient who was on ventilator and being ventilated for past few days suddenly pulls out the endotracheal tube. What is the next best step of management? ठीक है, एक patient है ventilator पे, being ventilated for the past few days, suddenly he pulls out the endotracheal tube. What is the next best step of management? A. Assess the patient, give bag and mask ventilation and look for spontaneous breathing. B. Start bag and mask ventilation and re-intubate. C. Sedate and re-intubate. And D. Make him sit and do physiotherapy. What should be the answer for this? Patient who was on ventilator and being ventilated for past few days suddenly pulls out ETT. What is the next best step of management? Assess the patient. Is it A? Assess the patient, give bag and mask and look for spontaneous. B. Start bag and mask and re-intubate. C. Sedate and re-intubate. Or D. Make him sit and do physiotherapy. What should be the answer for this? I'm waiting for the answer. What are the clues which are given in the question? I'm sorry. A patient has suddenly he pulls out the ETT. If the patient is himself pulling out the ETT, that means the muscle power is present. Yes, Dr. Kunal, it should be A. Okay, and if he is pulling out the ETT, the muscle power is present. We just have to assess the patient. If the patient can maintain the saturation and the work of breathing is not eased. Okay, so we will assess the patient. Okay, initially we will give bag and mask, and then we will see how is the spontaneous breathing of the patient. If the work of breathing is more is okay, if the patient is able to maintain the saturation, okay, so then it's okay. We'll just continue the patient on room air or on the face mask. Okay, there is no need to re-intubate the patient. ठीक है, there is no need to re-intubate कब करेंगे, अगर there are conditions, okay, which are telling if the respiratory rate is more than 35, if the tidal volume is not maintained or minute ventilation is not maintained, the patient is not able to cough out the secretions, okay, cough reflex is not present, then we have to re-intubate the patient. But in this patient, he has suddenly pulled out the ETT, muscle power is present. Okay, if the pathology for which we intubated the patient is okay, if the patient is conscious enough, then we can just assess the patient. We can just assess the patient. Is it clear? Is it clear? So the answer is A. Now, coming to the next question, question 10. Which of the following is correct regarding pulse oximetry? A. Measure oxygen saturation in arterial blood. Isosbestic point of oxygen and reduced hemoglobin are 940 and 660 nanometer. Usually heart rate cannot be measured. Okay, or D, all of the above are correct. What should be the answer? What should be the answer in this? Which of the following is correct regarding pulse oximetry? Measure oxygen saturation, isopestic point of oxygen and reduced hemoglobin is 940 and 660. Usually heart rate cannot be measured, or D, all of the above. What should be the answer for this? What should be the answer for this question? This is the last question for today's session. Please answer. Pulse oximetry, I have discussed it in detail during the classes. So what is correct regarding pulse oximetry? Measure the oxygen saturation, isosbestic point of oxygen and reduce hemoglobin are this. Usually heart rate is not. Dr. Kunal, what is the answer? Are you sure? Are you sure? Are you sure about this? Please read the question carefully. Please read the question carefully and then tell. Please tell the answer. Please see. Okay. See the pulse oximeter. Okay. The pulse oximeter. What does it do? Okay. The pulse oximeter. Okay. It is a device. See. This is the finger. Okay. The pulse oximeter. This is the pulse oximeter. It has a light diode. Okay. Light diode. And okay, and this is the sensor. This is the sensor. Now this light diode, okay, there are two types of light which are coming out of these. These are the infrared and the red lights. Okay, infrared and the red light. Okay, for the infrared, okay, for the infrared it is 940 nanometer. Okay, and for the red light it is 660 nanometer. Okay, for the infrared it is 940 nanometer. For the red light it is 660 nanometer. Is it clear? तो ये फिंगर है, ठीक है, ये यहाँ से लाइट एमिट हो रही है 2 वेवलेंथ की, एक तो इंफ्रारेड हो रही है और एक हो रही है रेड लाइट. नाउ डिपेंडिंग अपॉन द ऑक्सीजन which is bound with hemoglobin, depending upon the reduced hemoglobin or the oxygenated hemoglobin, ठीक है, depending upon the reduced and the oxygen, sorry, I'm so sorry. Okay, now what will happen, जो ऑक्सीजनेटेड हीमोग्लोबिन है वो कौन से कलर का दिखता है, दैट इज रेड इन कलर. सो द ऑक्सीजनेटेड हीमोग्लोबिन it absorbs more of infrared, ठीक है, more of infrared light than red light. ठीक है, तो ऑक्सीजनेटेड ब्लड, अगर ये ऑक्सीजनेटेड ब्लड है तो इंफ्रारेड जो आ रही है, इंफ्रारेड बहुत ज्यादा एब्जॉर्ब हो जाएगी और रेड लाइट कम एब्जॉर्ब होगी. ठीक है, जस्ट रिमेंबर ऑक्सीजनेटेड ब्लड इट एब्जॉर्ब्स मोर ऑफ इंफ्रारेड दैन द रेड लाइट. ठीक है, एंड देन वी गेट द saturation. Deoxygenated blood it absorb more of red light and less of the infrared light. ठीक है, नाउ ये जो पल्स ऑक्सीमीटर है, पल्स ऑक्सीमीटर व्हाट इट इज टेलिंग, पल्स ऑक्सीमीटर इट इज टेलिंग अस अबाउट द ऑक्सीजन सैचुरेशन. इट इज टेलिंग अस हाउ मच ऑक्सीजन, ओके, हाउ मच ऑक्सीजन इज बाउंड टू hemoglobin, how much oxygen is present in the oxygenated form. ठीक है, how much oxygen is bound to hemoglobin. It is not telling, okay, it is not telling us about the dissolved oxygen. It is just telling us about the how much oxygen is bound to hemoglobin in the arterial blood. It does not tell us about the dissolved oxygen and therefore it does not tell us about the total oxygen content in the blood. So our option was measure oxygen saturation in arterial blood. Yes, because it is able to differentiate between the arterial and the venous blood. It is able to get the pulsatile flow. It is able to detect the pulsatile flow, that is the change in the frequency of the light during the pulsatile flow, and therefore in the arterial blood, yes, it measures the oxygen saturation. Okay, that's why the oxygen saturation is less in cases of shock or whenever the vessels are constricted, okay, because there is no pulsatile flow. Okay, isobestic point for oxygen and reduced hemoglobin, it is 660 and 940. Heart rate can be measured. You all must have seen the pulse oximeter. You all must have seen the pulse oximeter during the COVID times, what all it is telling. So I'll just add a slide in this. Okay. So the pulse oximeter, is it clear, Dr. Kunal? Is it clear? It tells us about the oxygen saturation of hemoglobin, how much oxygen is attached with the hemoglobin. It does not tell us about dissolved oxygen. Dissolved oxygen नहीं बताता है and therefore does not tell us about the total oxygen content. ठीक है. Thirdly, it tells us about the tissue perfusion. It tells us about the tissue perfusion. How is the tissue perfusion? Because it is able to differentiate amongst the pulsatile flow and the non-pulsatile flow through a graph which is known as a plethysmograph. So it tells us about the tissue perfusion. It tells us about the heart rate. The heart rate is displayed in the pulse oximeter. So these are the features which is told us about the pulse oximetry. Okay, now errors. Remember errors in pulse oximeter. Pulse oximeter is, first, if there is any shaking, the patient is shivering, constantly moving, then it will give us the false result. Okay? If there is presence of nail polish, that will also hamper with it because of the use of cautery or BP cuff. Okay, BP cuff in same arm. Okay, and very important in cases of carboxyhemoglobin and methemoglobin. Okay, it gives us the false value. What happens? Carboxyhemoglobin, okay, it gives false high value with pulse oximeter. Why? Because the absorption of the light is same as that of the normal blood. It absorbs more of infrared, less of red light. Okay, so it gives us false high value. And methemoglobin, it absorbs both the infrared and the red light in the same ratio, so it is also giving us false value. Is it clear, Dr. Kunal? Is it clear why the answer is A? Why the answer is A? Any doubts in this? Any doubts in this question? Others, any doubts in this? Which of the following is correct regarding pulse oximetry? Is it clear? Is it clear? Any doubts? Okay. So that was all for today's class. On the Telegram app, we have a channel, livedaily.me or NEET PG. Okay. For what is the wavelength? What is B isobestic point of oxygen? That is the wavelength of light which is absorbed by the oxygen. Okay, Dr. Kunal is asking about the B option. Okay, the wavelength of light, okay, which is absorbed by the oxygenated blood. Okay, it absorbs more of 940 and less of 660. Okay, just give me a second. Dr. Kunal, guys, Dr. Kunal, it is reverse, right? The wavelength of light for the oxygen, for the red light, it is 660, and for the infrared, it is 940, and therefore the answer for this should be A. It should be A. B में it is ulta. For oxygen it is 660 and for the hemoglobin it is 940. Read the option carefully. Okay. So that was all for today's class. On Telegram app, we have a channel, livedaily.me or NEET PG. Through this channel, we are daily posting when will be the classes held, the schedule for the classes. Okay, and tomorrow on special class at 11:30, we will be having okay, clinical based questions. Yes, it is oxy-infrared is... Okay, Dr. Kunal, just I'll check this point and let you know. I'll just check this point and let you know. Okay, isobestic point of oxygen and reduced hemoglobin. Okay, so oxygen... I'll just let you know about this. Okay. I'll just post it in the group. Please, in the Telegram app, I'll post it. Okay, so the schedule, the special class, that is 11:30 a.m. clinical based questions, and on the YouTube at 7:30 p.m. tomorrow we'll be having a class on oxygen therapy devices. Okay, so this will be our schedule. And please install the Unacademy Learning app and go to NEET PG, get the plus subscription, and by getting the plus subscription, either for 12 months or 24 months, you can apply my code, that is Apoorva Life, and get 10% discount on the same. And on the YouTube we have a channel, NEET PG channel. Please subscribe to it, click the bell icon, like and share. And also you can use the referral code, that is Apoorva Life, and get 10% discount on the same. And Dr. Kunal, I'll just for once more read through it and then let you know about the option B. Okay, about option B. I'll just let you know about that. So that was all for today's